Live.
All right, we are live. Episode number 6. Elite Extra. Providing extraordinary support for people who lead extraordinary lives. My name is Dr. Brad Gilden, and I'm your host, along with my business partner, Stephen Krzyzewski. We're here every Monday, 12:15, talking to our various physical therapists, personal trainers, Pilates instructors, on all things related to the culture here at Elite. We're talking about all the different advances in physical therapy, wellness, and really having healthy discussions about how to keep your body, mind as fit as possible. I'm really excited today because my good friend and a woman that I look up to so much, both professionally and personally, she is a doctor of physical therapy. She specializes in both men and women pelvic floor health, and she also serves a dual role here at Elite Health Services. She is one of the owners of Elite Pilates, which is, as you saw Corey Radke discuss, our very unique approach to Pilates. Tara Gibson is the creator of the Pilates program, which has a very specific focus on pelvic floor and low back health, which I'm really excited to talk about today. So, Tara, welcome to the show.
Thanks, Brad. It's good to be here.
Very excited to have you here. So the first thing that I just want to kind of talk about is, what is pelvic floor health, and how come people really don't know about it?
Well, the men's and women's health, as well as pelvic floor health, which is basically a subcategory of men's and women's health, is a very under-discussed and underserved population of people. And I think that's why there's a bit of a stigma associated with talking about the pelvic floor, and I'll explain what that means as a pelvic floor in and of itself. But I think because of the stigma, and because it's an uncomfortable and rightly so private topic, it's not something that people are very comfortable talking about, even to their doctors in some ways. And I don't know that a lot of doctors are always, asking the right questions that might help them identify a problem in that area. So if we're looking at patients with a pelvic floor component, you need to understand what the pelvic floor is. So all people have a pelvic floor, not just women, and I think that's been kind of a common misconception. I saw that on national television once.
Yes, you did. A very famous doctor who said, well, I'm glad I don't have a pelvic floor, and that doctor happened to be a male. We won't name names.
No one's naming any names.
It's a little embarrassing.
So pelvic floors exist across the board. Even children have pelvic floors. Animals have pelvic floors. So anyway, the floor of the pelvis is something that I'll talk about a little bit today in terms of what I treat as a physical therapist. I have a female pelvic floor model. Unfortunately, I don't have a male model to demonstrate. However, in terms of the musculature of it, it's actually almost identical. The organs are obviously different, and the pelvic bony shape is also going to be different in a man versus a woman. So the pelvic floor is defined as all structures, not just the muscles and the fascia, but the ligaments, the nerves, the vasculature, and anything that actually runs between 4 bony landmarks. So I'm going to show you what they are in this pelvis and show you the model. So the pubic bone sits in front. You have your 2 sit bones. We call them ischial tuberosities, but people will often refer to them as their sits bones. They'll talk about that sometimes in yoga, for instance. And then you have the coccyx, or the tailbone. So they form a diamond, and the primary structures that we're addressing when we talk about pelvic floor are falling between those bony landmarks. So first of all, you got to get bold and look at a pelvic floor model. Now, we don't have the actual genitalia attached here, but we're looking at the muscles themselves. And the fascia is not seen in this picture, but you're seeing the musculature, and you're seeing the orifices, or the holes in the body that are part of the pelvic floor. So just below the pelvic floor, you have, in this model of the female, the clitoris, the urethra right beneath that, the vagina and the anus. So in a male, you would have basically just the anus in terms of an opening, and then actually the urethra as well coming out of the penis. So we have to talk about these things. So you have to use certain words out loud in the pelvic floor that most people are a little bit uncomfortable discussing.
But once they hear it, they get desensitized a bit,
and they just start saying it for fun.
Penis. Vagina. All right, enough of that. Mikey's getting uncomfortable, our photographer.
Now, okay, so moving on from that. So we look at the muscles that are involved, and we have front muscles, we have rear muscles, and we have superficial or on the surface muscles, and then we have a deeper layer of muscles as well. And then we even have muscles, some of you may be familiar with a deep hip rotator muscle called the piriformis. Oh, my piriformis hurts. I have sciatica, and it's often associated with that. And you're looking at that muscle coming off of the sacrum here. And then you also have what's called the obturator internus muscles, which is another deep hip rotator muscle that also comes off the sacrum and attaches to the ischial tuberosity. So, I'm sorry, not to the ischial tuberosity, to the greater trochanter of the hip. So you have all these important muscles in the pelvic floor that are affecting our function. And I think people don't understand what type of issues are involved with that, and so they don't know what the purpose of even talking about the pelvic floor is. So I think that's why it's not really discussed so much, but we can talk more about the issues associated with it.
Yeah, would love to go into some of that.
Yeah.
Maybe some of the most common issues that could be related to pelvic floor problems that
we might treat.
Yeah.
Well, the most common pelvic floor related issues that I address, and there are a multitude of issues, but the ones that are most common in women in particular are incontinence. So if a woman has, for instance, gone through pregnancy or even has approached and gone through menopause, there are certain changes that happen in the body that will often lead to a little bit of a leaking issue. And that's, it's not as cut and dry as just we have to do Kegels. Many of you may have heard, oh, my doctor said just do Kegels. It's also actually pronounced Kegels, but I pronounce it Kegels because it's just what comes out. So I say it's interchangeable for anyone who's noticing that. Tomato, tomato. But the Kegel is a strengthening exercise that was designed by a man whose last name is Kegel, who was teaching a woman how to activate the pelvic floor muscles so that she could maintain urinary and sometimes even fecal, as in like a bowel movement, continence, so that she doesn't have leaking. Well, that applies to a man as well, but it usually is something that the women have more of an issue with because of just the structure, and that the urethra loses some of its support for multiple reasons. But it's usually associated with a weakness. However, there is often very much a tightness, a constriction, a holding pattern in the pelvic floor muscles that can also lend itself to issues associated with incontinence, as well as other pelvic floor issues. So moving on from leaking, the person who sneezes or coughs and then leaks versus the person who can't make it to the bathroom and they leak too. Those are two different types of leaking, but they're both pelvic floor issues that need to be addressed. Another major area that I deal with, and this affects both men and women, is just pain. So there are many reasons for it, but when you hear the term pelvic pain, you're generally referring to pelvic pain that is associated between the pubic bone and the coccyx, like in the what we call the perineum area, or the vaginal or rectal area, or under the penis around the scrotum. Somewhere between those sit bones hurts. Now, there can be pelvic pain in the very, very low abdomen, like just above the pubic bone, that can be associated with menstrual cramps or sometimes a UTI or bladder infection, things of that nature. Hernias, sports hernias, can also cause pain down in the pelvic bowl. Digestive problems, like just having things like bad constipation or irritable bowel syndrome, things along those lines are also going to affect the pelvis because those organs run in the pelvic bowl as part of their path. So pain in any of that area would be considered pelvic pain, primarily actually under the perineum, and usually sometimes inside the vagina, inside the anus, somewhere along that area, the rectum. Tailbone pain, coccydynia we call it, that's another area that's very much affected that I will treat. Pudendal neuralgia is another common unfortunate condition that's very painful, and the primary nerve that innervates the pelvic floor is the pudendal nerve, and that can often become very irritated, inflamed on like a cyclist or someone who's had sort of, even a birthing trauma can cause this. Pain with intercourse, pain with sex. That's one that I think is really not discussed enough for both men and women. That can be associated with just pain having intercourse, or pain with an orgasm, or the lack of orgasm is another pelvic floor dysfunction. But all of these things can be addressed with pelvic floor physical therapy, and it's something that we're trying to get the word out on, because a lot of the pelvic specialists in our medical field, i.e. the obstetricians and gynecologists, and the urologists primarily, and even colorectal specialists, don't often know that there is a physical practice that can help. Physical therapy is something that is just entering the field, as in like the last few decades, where it's finally starting to be known that we can address this area. And I would say even just the last 10 years, that it's really starting to come to the forefront. And even now I see people all the time that said, that say, I had no idea that there was anything like this that could help me. And so I'm always trying to reach out to the doctors.
Yeah, so can you clarify, I think it would be really helpful for the people out there to know kind of the difference between what you would do from a pelvic floor standpoint versus what a OBGYN would do.
Yes.
And would somebody come to you prior to going to their gynecologist for a specific issue? So if you can maybe make
Well,
that
they could. Now, whether someone's going to come to me first versus going to their physician may depend on the state and whether you have a right to practice. As a doctor of physical therapy in the state of Connecticut, depending on the insurance, insurance coverage is a different thing. Someone can come see me directly off the street, and I am considered competent to evaluate whether or not I should be treating them or whether I should be referring them to see a physician. So you can come see me first off. Oftentimes, though, you will want to see your medical specialist to rule out any sort of medical condition that could be contributing to the problem. And then hopefully they will refer you for physical therapy. If they don't, you're still able to come see me. So it's the difference with, for instance, and if you go to your OB-GYN and they're going to do a pelvic exam, we're not technically doing the medical definition of a pelvic exam. We're not looking for the same things. They're looking at the histological structure of the cells. They're looking at the healthiness of the organs themselves, and the actual function of the pelvic organs themselves, and the tissues, the physiology. What I'm looking at as a pelvic floor specialist in this case is the function of the soft tissues and bony tissues, the orthopedic component. We're looking at the muscles, we're looking at the fascia, or the connective tissue that covers the muscles, the ligamentous structures around them, the nerves, and the vasculature to a degree in that area. It's not my main specialty. Most of us are myofascial specialists. And then we're also looking at the bony structure of the pelvis, of the hips, of the sacroiliac joint, of the lumbar spine, all of that in particular. And then finally, we're also looking at the lower abdomen to see, are there restrictions on a muscular and fascial level that are affecting the function of the pelvic floor? And so when I'm feeling for things, I will actually, with the comfort of the patient and with a signed consent form, perform sometimes an internal examination, whether interrectally or intervaginally, depending on what their issue is, to determine whether or not there's a problem. And I'm trying to be very respectful and mindful of how personal that issue can be, and it's a very carefully constructed process. So that would be the main difference in terms of what I do.
And are all pelvic floor treatments always internal?
That's such a good question. No, because there are people that, I don't care what I say to them, they don't want anybody going near there except their doctor. And I respect that. And there are many reasons why someone may not want that. I mean, there's obviously histories of abuse. There's just histories of people that feel very private, who don't feel comfortable with that. And that is always respected. So much can be treated that does not involve an internal treatment in and of itself. One of the main issues that affects the pelvic floor dysfunction is often just how someone breathes. or how they hold themselves in a postural way. Sometimes even their diet. But a lot of times it just involves how do we get the right muscles to work or to relax. And I can teach them that through exercises for the pelvic floor, through exercises for the hips, through exercises of just diaphragmatic breath, so that they can learn, oh, this is what I can do to help myself, and I can help, with the parts of the body that are not in a functional position, I can help achieve that for them, and then help them help themselves through movements and postures and just self-treatment techniques so that they don't require the internal work. So that's always an option.
So you're not just looking at the pelvic floor in isolation. You're kind of looking at the whole kinetic chain.
And that is where, like, as a functional manual therapist, which was my first certification after becoming a physical therapist myself, and before developing a focus on men's and women's health and developing that specialty, that approach is looking at the whole system. And so first and foremost, and perhaps finally, even as a pelvic floor or women's or men's health specialist, we're looking at the whole body. So I may go and treat something in the ankle that I feel is affecting what their hip position and therefore pelvic position is doing, and or I may go up and treat something I find around the neck or the TMJ that is affecting their ability to breathe well, or to sit in a good postural alignment. So we're always trying to look at the whole picture. And oftentimes, I'll tell you what, there are pelvic floor patients that come in with true pelvic floor symptoms. I don't have to do a pelvic exam on some of them. I just have to address something that might be at their TL junction where their thorax meets their lumbar spine. That in and of itself can sometimes affect what's happening, particularly with a man, and sometimes like scrotal dysfunctions. Sometimes, well, we haven't talked about men yet, but that's something we could talk about in a minute. But I mean, we're looking at the whole picture, and sometimes, often, it's the entire system. It can be fascial tissues in the legs that are pulling on the pelvic floor. So we're always looking outside the box.
And I think that's missed a lot if you just focus on one specific area where the pain might be. You're missing the big picture that could be driving that pain.
But it's like, as you've always said, Brad, it's so important that we touch the pain so that someone knows we really hear them. And that is often what I try to do. Is this where it hurts? Right. And oftentimes there is something tight or holding there or weak, and we have to train those muscles to work properly. Sometimes after, just after going through a pregnancy or even menopause, certain organs in the pelvis can shift in position, and that can be causing a weakness or even a pain. And I have to sometimes touch that area to say, okay, this is where the problem's happening. This is where your symptom is happening. But the reason it's falling is because of the alignment of your pelvis and your posture. So that's where we're looking at the big picture.
So where's the entry point for a lot of these patients? Where are they coming in to how do they hear about you? Is it their physician?
Well, oftentimes, at this point, I would say it's still through the physician. And that's wonderful. It's one of my main goals is to just develop more of that network.
That collaborative.
Yeah, I really want to work with more doctors, and there are many things that as a physical therapist, it's not my scope to treat it, and sometimes a patient really requires surgical intervention, certainly a medical treatment, but I think it really goes both ways. And so most of the time I am getting my referrals from urologists and gynecologists. After that, I start to get more through word of mouth. I work with a couple different postpartum groups that I have relationships with, and the groups themselves are now a network where they communicate, and I will sometimes give a workshop to talk about what can pelvic floor physical therapy do for you. Not just pelvic floor physical therapy, which would segues into just what women's health, but anything associated with pregnancy and postpartum care is women's health. So it could be anything associated with, the stomach tissue becoming split, called a diastasis recti. That is something, when that linea alba opens up from the belly stretching, that can really affect the structure of the core. And I haven't talked a lot about the core yet, but that's a big part of pelvic floor health. So pelvic floor is part of a women's health or a men's health, discussion. So those groups are another reference point for referrals, and then we can address the entire picture on them, part of that being their pelvic floor.
That's Sounds good.
Yeah.
So we've talked a lot about women and
Yeah.
and pregnancy and postpartum. What about us guys? I mean, I'm sure the guys are kind of the last to come in, but you know, I know that a lot of men suffer from back pain, so to speak, that might not be coming specifically from the low back. It could be coming from another area that leads to a lot of the dysfunction and inability to perform on the field or even at work. They can't sit at their desk because of pain. So what kind of things are you seeing with men, and is the knowledge base growing out there that this exists?
That's the newest. That's the area that I think if we could get more of the word out for that we would really be able to help a lot of the male population. The types of things I see men for, oftentimes, I mean, look, I'll see a man for a low back issue. Oftentimes they could see any of our great therapists or see someone who can treat the low back, and they'll make a huge change, you know, with anything that a general good orthopedic physical therapist might look at. The missing component is that the floor of the pelvis is what is very difficult to address on most people, and it's what's supporting the whole structure. So not only will men come in because they are having low back pain, but when they know there's someone that can help them, they'll come in for something more specific to the pelvic floor, like my tailbone hurts when I have a bowel movement. My scrotum hurts, and I don't know why. It feels really tight, like it's being pulled inside me, and I can't release it. The biggest topic that I think is not discussed enough, that generally I have made some changes with, and I know a lot of pelvic floor specialists do, is even erectile function. Now, not across the board. There are different types of erectile dysfunction, and a lot of times that is truly a medical issue. But there is certain types of dysfunction that are associated with tightnesses in the pelvic floor and in the fascial system around it. That can be due to certain surgeries in the pelvis, even from a hernia or hernia repair, you know, or in the groin area, from injuries to the low back that need to be addressed as well to kind of help with that issue, because the nerves, particularly from the sacrum primarily, are what are innervating the whole pelvic floor. And if the sacrum is not in a good alignment, or if those nerves are getting pinched, it can cause a pain or just a dysfunction of the organs. There's also a referral of pain that comes into the pelvic organs from the dysfunctions in the upper back region. So when someone's sitting in bad posture all the time or doesn't breathe very well, oftentimes that stress in and of itself to the system in the middle back can be contributing to a pelvic floor dysfunction in men. The other thing I see with men is the urinary. This can go across the board with men and women too, but less often a leaking issue unless they've had something like prostate cancer and have gone through prostatectomy or any multitude of treatments for prostate dysfunction. If there's a prostate issue or even just chronic prostatitis, that can affect the urinary sphincter because of their intimate relationship, and I don't have a pelvic model to show you this, but that can affect a man's ability to control his urine, and that can be treated sometimes by just working around the scar tissue. That can be performed externally, very deep through the abdomen, and sometimes just in the perineum under the scrotum, and then interrectally, just to kind of address what's happening in that area. Sometimes treatment directly on the penis is required, but oftentimes not. It's just around the prostate itself. That can affect urinary function in men and absolutely should be looked at by a physical therapist to see if we can help restore some of that function after surgery, or even just chronic prostatitis, often very much linked to just tightness in the pelvic floor muscles. But I would say the things that I'm working on with a man is often getting them, particularly with erectile dysfunction as well, or any sort of pain, to relax the musculature where we're holding so tightly. I think just in general in our society, men and women, but men in particular, you know, there's a need to really play a role that is about success and about being able to provide, and there's a lot of stress that goes along with that. Yeah. A lot of stress. And I think a lot of it,
breath holding, pelvic floor hold.
Yes, just gripping. And they don't know. You know, it gives the word tight ass a whole new definition. And that's what we see. Yeah, couldn't help myself. But I mean, I need to get people to really relax their gluteals and to relax the pelvic floor, and men in particular need help with this sometimes. And then retrain the muscles once they've relaxed. This goes for men and women alike. How do you get these muscles to function properly with good breath? How can you relax and stretch the muscles well? How can you keep yourself in positions that are going to help you maintain function? We even talk about that in terms of sexual function. Certain positions might be more effective than others for both men and women when you have an issue like this. So these are the kind of things we talk about.
So outside of kind of major trauma or surgery, what's kind of an average number of treatments that someone would need regarding pelvic floor? I know
that's
it probably
a very good question. Yeah,
varies.
there's a span. There's definitely a span depending on the issue and how long it's been there. Sometimes we find that the longer someone has had an issue, sometimes the longer it takes to get them better. So the sooner you address these issues, I find the easier it is to reverse or correct them. But I find that with someone with pelvic pain in particular, and a certain urge incontinence where they feel like, oh, I only leak when I put my key in the door and I'm getting home, or I hear water running, or I get really close to the bathroom, for instance, or I just have pain, it hurts when I have sex, it hurts when I sit. Those types of dysfunctions are often corrected a little bit faster in some ways for me, because I can manually help them relax those tissues, and then they can practice maintaining that. That might only be, 2 to 5 sessions to really make a big change there. Sometimes even just one, but it's just, you have to get comfortable with the work. None of the work, by the way, should really be painful. It's not something that should be bringing someone to a state where their nervous system is tense.
Because you don't want them to tense.
No. So though we might allow someone a little more pain if we're treating, for instance, their shoulder or their hip or something like that. When I'm doing a pelvic floor treatment, I try to keep them as comfortable as possible when I'm working on that area. So just so people know, it really shouldn't be painful. A little uncomfortable, but not painful. So 2 to 5 sessions for those. Now, someone who's been having leaking for years, or even the erectile dysfunction for a longer time, for instance, they may need a little bit longer to make changes. And I usually anticipate a good 50% change if possible in a lot of those. 30 to 50% change is what I anticipate with a lot of even the erectile dysfunction. I can't guarantee anything. It depends on the individual, but I definitely see enough of the change that they can see function improvements. And that can take sometimes a little bit longer, like upwards of 5 to 10, sometimes more depending on the issue, but those issues I described before are the ones that are usually correcting a little bit faster.
And what about homework for the patients? Are you giving them things to work on at home? And how much does that play into
It's huge.
Improvement?
I came into pelvic floor physical therapy because I was a patient myself. I was a ballet dancer. I know what it is to be a tight ass, and I'm a perfectionist, and a little bit type A. And anyway, I felt, until I had treatment myself and it was identified to me what it meant to have pelvic floor dysfunction, I have my own complaints without going into all the details for my own private reasons that made me a pelvic floor patient. When I had that treated, it was eye-opening. The number one thing I realized was how much I was clenching my pelvic floor muscles all day and my jaw. And I was wondering why I would grind my teeth so much and have TMJ pain. My homework was, can you just relax your pelvic floor? Just let your butt go a little bit. Can you relax your abdomen and breathe into it a little bit? Can you learn to drop your jaw? And even now, I'm communicating on camera, probably a little nervous, and I'm talking a lot and kind of quickly, but the other thing is just learning to slow down, take a breath, be present, meditation. All of this becomes part of the homework. And when I found that in myself and changed that, huge difference. The pelvic floor treatments were just the start. And then for me, it's been about modifying and continuing to practice modifying my own lifestyle, my postural holding patterns, what it means to rest comfortably on my pelvic floor and not be sitting in a slumped position all the time, learning how to breathe differently, learning how to do gentle stretches to open the pelvic floor. I'll advertise for a second on Amy Stein's book, Healing Pelvic Pain. is it Heal Pelvic Pain or Healing Pelvic Pain? An excellent book, and she's been a big influence for me, and I think for a lot of pelvic floor therapists, by publishing this book and the videos that she included in that, the DVDs, because they give people the tools to go home and do some of the exercises themselves so they can start to feel and take responsibility. Oh, this is me tightening up. I have to learn how to open myself up and relax in order to improve my own function overall. And so very much I send them home with some stretches, like a happy baby stretch if you're a yogi, or even just holding your knees into your chest and holding onto your ankles and just breathing. I don't know if you want a demonstration or if this is kind of making sense, but just lying on your back and stretching those thighs and holding your ankles and just spending about a minute there so you can be with yourself and just notice your breath is just a huge pelvic floor release. Keeping the hip flexors nice and long, for those of you who know what the psoas is, and lengthening that out can be a huge release. The inner thigh adductor muscles need to be stretched very gently in order to release their pull, because the adductors and the deep hip muscles, i.e. the piriformis, they fascially connect to the pelvic floor and are a huge part of that tightness. All of that has to learn to let go and then strengthen in a healthy, careful way, again, along with the core. I believe, as you know, I direct our Pilates program, and I believe 100% in the Pilates system. If it's not taught keeping these things in mind, it can overly tighten the pelvic floor and cause a lot more tension and actually perpetuate a dysfunction. So learning how to teach and use a system that's core strengthening like Pilates in such a way that allows for a nice open breath and relaxing the pelvic floor in between exercises and not overly tightening and gripping as you do exercises can make a huge difference in returning to function. So that's Pilates taught from a pelvic floor perspective, right, as an example. So yeah, that's the homework I give.
Awesome. Well, I just wanted to give a plug to Tara as well. She is now in Westport 1 day a week, as well as being here 3 days in our old Greenwich office. Well, this was a ton of fun. I always learn from you, and I'm sure you out there learned a ton as well.
I'm always learning too, always.
So next week, episode number 7 on Monday, 12:15, same time, we're going to be hearing from physical therapist Jeffrey Walsh. Jeff is going to be talking about all things related to physical therapy, his experience with physical therapy and some of the trends that he's been seeing since he's started in this field. So thanks for tuning in. Really appreciate your support, and we'll see you here next week, 12:15 with Jeff Walsh.